friends here in attendance, and a very warm welcome to each one of you to today's academic webinar, which is organized under the aegis of the Endocrine Committee of the UP Chapter of Obstetrics and Gynecology. And on behalf of UPCOG, I extend my gratitude to all dignitaries, experts, and attendees who have joined us here this evening. Now, there is a saying in Sanskrit which goes, Yatra naryastu pujyante ramante tatrah devta, which means जहां नारी का सम्मान होता है वहीं देवता वास करते हैं. And with this in mind, we move ahead to discuss one of the most common maladies plaguing the women of today's era, that is PCOS. Today's theme, PCOS across life stages from teens to transition, is a topic of utmost relevance and importance. It affects the women across the entire spectrum of reproductive and even post-reproductive years, and we are here to explore it in depth with the help of our eminent faculty. It is now my privilege to invite Dr. Reena Srivastav ma'am, Chairperson of the Endocrine Committee of UPCOG, to share a few words and introduce the theme of today's session.
Thank you, Priyadarshini.
Thank you.
A very warm welcome to all my seniors, mentors, friends, colleagues, and experts. PCOS across life stages, teen to transition. This topic has been chosen for today because PCOS presents in a very, very different way throughout the life stages, from adolescence to reproductive age to the transition of menopause. So it has got a vivid presentation, and accordingly the diagnostic points are also different, and so would there be difference in the management of PCOS. That's why this topic has been chosen for today, so that we are all well versed how to diagnose and how to manage. With these words, I welcome you all, and I would invite our President, Dr. Saroj Singh, for a welcome address.
Great regards to our respected seniors, Madam Usha Sharma ma'am, Madam Meera Agnihotri, Dr. Manju Verma ma'am, and all the seniors who are here. And with great respect to our Chief Patron, Dr. Usha Sharma ma'am. Now, Endocrinology Committee has chosen very nice subject or PCOS for today's discussion. And we are sure that all our delegates who are joining us will be definitely benefited, because they have chosen it in a panel form. And questions are there right from teen to transition up to the menopause, different type of case scenarios they have chosen. And the moderators, Dr. Shikha Seth and Dr. Amrita, and with all the panelists who are bubbling with their knowledge are here. So we are 100% sure that all the delegates are going to be greatly benefited with this. Thank you so much, Reenaji.
Thank you, ma'am, for your inspiring words.
I request, yes, Dr. Sharma.
Now, as we move ahead, we are truly honored to seek blessings and guidance from our most respected mentors and patrons. I request Padma Shri Dr. Usha Sharma ma'am to kindly say a few words and bless the occasion.
Thank you very much, Preeti. I'm very happy today that Meera has joined, because in few of our meetings, she could not join us. And I always respect her and love her a lot, because she has always supported me and cooperated with me in the growth of this UPCOG. And not only she, I'm seeing here my past presidents, Manju Verma, Reena Srivastav, all of them have been so supportive, and a senior member like Ranjana Khanna, because I could not have done the way this UPCOG has grown without the support of you all. And then Saroj Singh is doing so well. I really can't imagine that somebody can do better than Saroj. And all the time she is thinking about one or the other thing. Madam, ye karwa le, madam, wo karwa le. And that really gives me a lot of satisfaction. And I really feel so happy that my president, past president, present president, and future presidents are so much interested in this venture of UP chapter of obstetrics and gynecology. And lot of nice things during her tenure of presidentship. Now she is chairperson of endocrinology committee. And today, Dr. Raj Vijay and Dr. Chandravati are not with us, but our vice presidents, Dr. Ranjana Khanna, as well as I think she's not here.
Sadhana.
SP? नहीं है ना वो?
Sadhana.
Not seen.
हमारी
Sadhana.
Sadhana Gupta.
Sadhana Gupta.
दूसरी है?
Ma'am, Dr.
अच्छा
Sadhana
चलो.
Gupta है ना,
And
vice
then
president.
we know president is Preeti, and secretary, all of us know Dr. Bharti Maheshwari. She is doing a very good job, not only for UP chapter, but also for Foxy. And every time, whenever there is a webinar, I always mention that she contesting for vice president or soon. And if she is our own candidate, and I will request you all to please support her and vote for her. Here, only one thing I will always add, that though our intentions are there to support her, but then we forget to vote. And so my main thing or the main request to everyone will be, please do not forget to vote. To whomsoever you vote, from 1st August to 10th of August, because it is our right and we should use this right. And so I will request you all to vote for whatever post you want, whomsoever you want to vote. And Reena, today you have selected a very good topic, PCOS. मैं एक बात यही कहती हूँ, फिर अनफॉर्चुनेट बात मुझे ऐसी लगती है कि एक बार जो पीसीओएस की लड़की हमारी मरीज बन जाती है, वो लाइफ लॉन्ग हमारी मरीज रहती है. उस बेचारी को ये कहना कि ये क्योर हो गया, हमें लिए एक सपना है. So I think the more we discuss this topic, maybe that more intelligent and wise we become. So you have really chosen a very good topic, and as you have given the name, that PCOS across life stages, teens to transition, is very, very fitting thing. And so I'm sure that today the deliberations will certainly help everyone and will benefit everyone to have our better knowledge regarding the diagnosis and management. And let us hope, I always say that I pray God, काश ऐसा हो कि ऐसा ट्रीटमेंट निकले कि हम अपने पीसीओएस वालों को ये कैसे कि ये क्योर हो सके. हालांकि we know that this is a hormonal disease which we cannot cure. It is something very natural and it comes from the genes, or you can say from the nature. But even then, we can give comfort to the patients of the girl, whosoever is suffering from PCOS. And we should differentiate between PCOS as well as PCOD. And at every time we should be there to see, to look after her hirsutism, at least symptoms we can treat so that she has got some kind of satisfaction. So, Reena, I will congratulate you for choosing such an important subject. And Preeti, your smile is all the time is really, really, I'm appreciating and admiring. To चुपचाप धीरे धीरे प्यारी प्यारी हंसी हंस रही है. And I'm sure that this
Thank you.
webinar will be very, very fruitful for every one of us. And I wish this program a great success. Thank you very much. And I wish you all a very happy, healthy, and bright future. Thank you very much.
Thank you, ma'am. Pehle to for all the happy and kind words you said about me, and also for your guidance in regards to this entire webinar in today's program. Thank you very much, ma'am. And now I request and welcome Dr. Meera Agnihotri, ma'am. Please go on to her CV, please. I request ma'am to share on her valuable blessings. Meera, ma'am.
Hello.
जी ma'am.
सुनाई पड़ा
Am I
नहीं.
audible?
जी
Yes.
ma'am.
Yes, ma'am. Yes, ma'am.
Yes, this is for Dr. Raj Bhaveja. Hello.
Yes,
Sunsar
ma'am.
ji, am I audible?
Yes,
हाँ,
ma'am. You are
मीरा
audible.
सुनाई पड़ रहा है.
At the outset, I extend my heartfelt gratitude to the organizing committee, President Dr. Saroj Singh in particular, and endocrinology chairman, that I have no guts to deny their order. As Usha ji has very correctly told, हम लोग एक साथ डाइट शेयर करते हैं तो हमें ऐसा लगता है कि वी आर कहीं ना कहीं से हम लोगों की ट्विनिंग तो है ही. हम ट्विनिंग्स तो नहीं कह सकते, ट्विनिंग तो डेफिनेटली है. We feel each other's heart very closely. We understand each other very closely. जैसा उषा जी ने कहा, at the outset, I will request all of you to kindly support Bharti for her work she has done, and it will also be an honor to our UPCOG also, that we are sending a person in the voting is very essential. Sometimes all of us intend to vote, but we may forget. तो एक दूसरे को याद भी दिलाते रहना चाहिए. और एज ए मेंटर, एज ए टीचर, एज ए गार्जियन, हम लोग का ये मन करता है कि हमारे जितने भी यंगस्टर्स हैं वो आगे से आगे जाएं. तो इट इज ए रियल ऑनर फॉर अस. जब कभी हम किसी कॉन्फ्रेंस में जाते हैं, कोई पैर छूता है, कोई आता है, कोई मेरा नाम लेता है, चाहे रंजना हो, चाहे एनीबडी, कीर्ति हो, तो वी फील रियली ऑनर्ड. तो अगर हमारा अपना कोई बड़ी पोस्ट पर होता है तो वी बिकम ए लिटिल ब्रॉड एंड आवर स्माइल्स बिकम ब्रॉडर एंड आवर eyes start sprinkling that this is from us. Regarding the subject, need not to tell anything. PCOS divided now into adolescent adult PCOS. It is not a disease of the lifetime from birth to onwards, but it is a transgenerational disorder. We travel from one genital order to other. Maybe third generation it may be depicted, maybe second generation. So epigenetic formulas are very much coming in action, and I believe the studies which you have kept must definitely discuss about the epigenetics. सरोज एंड निशा थोड़ा सा ये चाहते हैं कि जो हमारे अंडर ग्रेजुएट्स अगर इसमें पोस्ट ग्रेजुएट पार्ट ले रहे हैं तो दे मस्ट बी वेरी क्लियरली टोल्ड अबाउट adolescent and adult PCOS, because treatment strategies are entirely different. Diagnosis and treatment strategies are बिल्कुल different. Once upon a time हम लोगों के सामने अल्ट्रासाउंड की रिपोर्ट लाके पेशेंट अपने आप अपनी डायग्नोसिस बताता था, मैडम मुझे PCOS हो गया, प्लीज ट्रीट इट. Convince our youngsters that ultrasound findings may not be a part of the diagnosis now, especially adolescent के लिए, where the ovaries depict the same way, छोटे छोटे follicles उसमें आने को है. So these are the few things which we have to clarify seniors को, so that the treatment strategies go on planning in a different manner in the adolescent, in the childbearing, in the perimenopause, menopause, and to stop the transgenerational transition. I just don't want to add anything more than that, because experts are sitting over there. Please be very focused, so that clear-cut instructions goes to our postgraduates for treatment strategies. Need not to discuss about the theories and this and that, but the treatment strategy must be very correct. Because even today we know that sometimes you see prescriptions and you are disappointed that what is being written over here. That is what is there. और अपने मरीजों को दो चीजें जरूर समझाना है, एडोलसेंट हो या किसी एज ग्रुप में, कि ये जो हम लोग दवा लिख रहे हैं ये जरूर इस्तेमाल होती है फैमिली प्लानिंग और वगैरह वगैरह, बट इसका ये एक्शन हम लोग यूटिलाइज कर रहे हैं. सो इज अबाउट मेटफॉर्मिन और द ड्रग्स फॉर प्री डायबिटिक्स, दैट ये डायबिटीज की दवा जरूर है, बट हियर वी आर यूजिंग इट फॉर व्हाट पर्पस. सो दीज टू थिंग्स प्लस ultrasound report. If these three things are very clear in the mind, treatment strategies will automatically become good. Thank you, Saroj, President and Endocrine Committee Chairperson, President Dr. Rana, lovely Preeti, Amrita, and everybody. Mera namaskar and best of luck for the best outcome for this epigenetic disorder which is traveling from transgeneration. You will be discussing one part from birth to this thing. Very good it is. And thank you, Usha ji, for talking about me. It gives me a real pleasure. We want to continue for long. Baki Bhagwan ki marzi. Thank you very much once again.
Thank you, ma'am, for your kind words and your blessings. And I can see Dr. Chandravati, ma'am, has been able to join us today, and we've been blessed with her presence. So I request ma'am to grace us with a few kind words if she's.
I'm not able to see.
I didn't see Chandravati, ma'am.
I could not see her.
That is Dr. Manju Verma. She has been wrongly labeled.
Oh, भाई वाह मंजू मंजू तेरा चंद्रावती लिख के कैसे आ रहा है?
आज मैडम आपका प्रमोशन हो गया।
कह रही हूँ मेरी जो है मेटामॉर्फोसिस हो रही है हर उसमें।
मुझे लगा मैम साइड में चंद्रावती मैम भी होंगी।
नहीं
नाम उनका आ रहा है तो
चलो
रॉन्गली लेबल्ड हो
आगे
गया ना
बढ़ो
डॉक्टर
बेटा,
मंजू
आगे।
वर्मा का। आई वाज
जी, जी।
वांटिंग टू पॉइंट इट आउट, फिर मैंने कहा चलो इट मे गो अननोटिस्ड।
नहीं, आई वाज थिंकिंग दैट सिंस शी इज स्पीकिंग तो करेक्ट हो जाएगा क्योंकि पहले सही आ रहा था।
चलो ठीक।
दैट मींस गॉड वांट्स मी टू चेंज।
रीना तू अनम्यूट कर अपने को। रीना
रीना मैम आप म्यूटेड है।
हाँ
Madam Chandravati is not well to join the
Yeah.
webinar today. She has extended her good wishes and blessings to this UPCOG and this webinar in particular.
Thank you, ma'am. With this, before we commence the scientific session of the evening, let us take a moment for the Saraswati Vandana and the symbolic lamp lighting ceremony. And I request all our dignitaries, experts, and attendees to join us virtually with folded hands in this moment of positivity and auspicious beginnings.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणि विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा।
Thank you everyone for joining in with the prayers with us. And now the academic segment begins. We are all looking forward to insightful discussions and clinical perspectives. And the moderators of today's panel are Dr. Shikha Seth ma'am, Professor and HOD at AIIMS Gorakhpur, and Dr. Amrita Jaipuriar ma'am, Consultant Gynecologist at Jaipuriar Medical and Research Center and Garg Hospital. Joining us, please move on to the next CV. Next, please.
Ma'am, I have displayed the CV, ma'am. Amrita ma'am CV.
अन्य change कर दो experts.
Okay, ma'am.
Joining us today as experts are Dr. Saroj Singh ma'am, President of UPCOG and Professor at FH Medical College, Agra, and ex-HOD and Principal at SN Medical College, Agra. Second expert of the day is Dr. Reena Srivastav ma'am. Please change. Who is the chairperson of the Endocrine Committee of UPCOG and ex-HOD at BRD Medical College. And lastly, Dr. Seema Hakim ma'am, please change. Ma'am is ex-professor and chairman OBG at JN Medical College AMU and is presently the president of Aligarh chapter of ISOPAB and consultant at Malik Hospital, Aligarh. Our esteemed panelists for the sessions include Dr. Vani Aditya ma'am, professor and ex-HOD at BRD Medical College. Next, please. Dr. Meenal Jain ma'am. Ma'am is professor OBG at SN Medical College, Agra. Next. Dr. Shikha Sachan ma'am. Ma'am is professor, Department of OBG at BHU. Next, please. Dr. Amita Tripathi ma'am is consultant OBG at Allahabad and is the honorary secretary of Allahabad Menopause Society. Dr. Garima Gupta ma'am is associate professor at GSVM Medical College at Kanpur. Dr. Aruna Verma ma'am, professor at OBG at LLRM Medical College, Meerut. Dr. Kanhaiya Agrawal, the consultant endocrinologist, hormones and diabetes care at Gorakhpur. Next, please. Dr. Priyanka Sisodia, assistant professor OBG at AIMS Gorakhpur. Next. So with this, we have covered all our panelists for the sessions. And I now request the moderators of today's panel, Dr. Shikha Seth ma'am, Professor HOD at AIMS Gorakhpur, and Dr. Amrita Jaipuriar ma'am, to please take over and begin the discussions on PCOS across all life stages. Over to you, ma'am.
थैंक यू प्रीति। सभी गुरुजनों को सबसे पहले मेरा प्रणाम। मैं डॉक्टर शिखा सेठ, प्रेजेंटली वर्किंग एज प्रोफेसर इन हेड डिपार्टमेंट ऑफ ऑब्स्टेटिक्स एंड गायनेकोलॉजी, अपने सहयोगी डॉक्टर अमृता मैडम के साथ इस पैनल के एक्सपर्ट्स डॉक्टर सरोज सिंह मैम जो मेरी टीचर रही हैं, डॉक्टर रीना श्रीवास्तव मैम एंड सीमा हाके मैम, और साथ में अपने सारे सहभागियों, बाकी मेडिकल कॉलेज से जुड़े हुए असिस्टेंट प्रोफेसर एंड कलीग्स का स्वागत करती हूँ। एंड लेट्स स्टार्ट with the session today. And first of all, I will like to say thanks to the whole endocrinology committee of UP chapter to have a faith on me and giving me the opportunity to prepare this thing, and the guidance from Dr. Reena ma'am, who has suggested this topic to be taken care of in this session so that we can check the whole series of things. Just give me 1 minute so that I can share my presentation. दिख रहा है? Is the
Yes, ma'am.
visible?
Yes, ma'am.
Okay. So let's start this presentation. It is, as everyone has suggested, that PCOS is a lifelong disease. Once a woman becomes a girl or a woman becomes a patient, she remains a patient throughout her life with us. So we will be discussing all those problems, the dilemmas which we face from the birth of a baby to the menopause in this particular session, in the form of different scenarios which we will be discussing. So we all know that PCOS is the most common endocrinological disorder. It's a hormonal imbalance which remains there with the girl since its birth, manifests differently throughout her life cycle as the age changes, as she changes from teenager to an adolescent, and then the reproductive phase, then perimenopause and menopause. So there are different challenges which come across, and we will be discussing those all challenges through our case scenarios. We all know that a Rotterdam criteria, which is the diagnostic criteria for PCOS, but this criteria works only for the reproductive age woman. This has 3 things because the pathology starts from the ovary, which is thickened and enlarged, hyperthecotic, produces excessive androgens, and ultimately there are follicles that do not ovulate and presents with menstrual irregularity. So there is all things which are there, and it presents itself from the reproductive age group. But we can have different various phenotypes of this disease, and all the 3 things are present. All it is called as classical phenotype, and when the two factors are there, and it is basically can be a different phenotypic variant. The commonest one is the the classical PCOS, where the patient is usually obese, hyperandrogenic, oligomenoric. And the rarest one and the most difficult one to diagnose is the non-hyperandrogenic type of PCOS, the type D, where there is no androgenic features. Until unless we do an ultrasound, we don't know about the ovary morphology. And these patients are usually lean and thin also. So it is only from the anovulatory cycles or the menstrual regulations we can identify it. So we know the criteria for diagnosis in reproductive age group, but simultaneously behind these diagnostic criteria, there are some metabolic changes also, which goes on. And because of these metabolic changes, we have a different presentations in later life also. So because of these challenges, we have chosen this topic today, and we as it already been said by Usha ma'am, that we come across different presentations, different variants in the different stages of a woman, and that all poses. And recently it has also come up, this Meera ma'am also has said this, that even in utero, the hyperandrogenic environment, the PCOS pathophysiology, it affects the fetus in utero itself. On the fetal programming, it leads to some epigenetic alterations. Ultimately, the fetus in utero becomes programmed to develop the metabolic complications as well as the reproductive complications in the form of abnormal hormone profiles. So PCOS is also a transgenerational disease, and it is basically the androgen that is responsible for this. Let's start after this, just a brief of about the pathophysiology, because we will not be discussing it further. We will just be discussing the patient's presentation and the values. So let's start with our first scenario, that is a 25-year-old average built girl who is having the complaints of prolonged cycles. She at times bleeds only with the progesterone therapy, married since last 4 years and now eager to conceive. On examination, she was found to have 50 kg weight, BMI is 22.2, general examination is all within normal limits, except that she has got some excess hair on thighs and abdomen. So the question first I will like to put to Dr. Meenal Jain. With this history and examination, what will be the investigation scenarios in this particular woman, Dr. Meenal?
So good evening, everyone, and thank you so much for making me a part of this very informative panel. The question, the case scenario that has been put over here is of a 25 years old with a BMI normal lady who is on history. She's telling us that she bleeds on progesterone treatment. So this gives me an indication that her endometrium must be a proliferative one, and she needs progesterone for the bleeding. That is, she is having an anovulatory cycle, and since she wants to conceive, so the first thing that I would like to investigate upon her should be a hormonal profile consisting of a day 2 FSH, LH, then the thyroid profile, TSH, T4, a prolactin, also a serum AMH, and definitely a transvaginal scan to look for any associated uterine pathology, to look for the ovarian antral follicle count, to look for endometrial thickness and even the pattern of the endometrium. Then I will also like to get done, since OGTT will be required, and since we know that insulin resistance is a part of PCO, which is the most common cause of anovulatory cycles. So considering that fact in mind, considering insulin resistance to be at the base of all this, I would like to get a HOMA IR also done for her. And to investigate for her infertility workup, she requires an HSG, and the male factor has to be examined by a husband's semen analysis.
So thank you, Dr. Meelal.
I would like to do in the first.
Absolutely right in that sense that because she is oligomenoric and anovulatory appears to be clinically anovulatory. So we will like to check the hyperprolactinemia and hypothyroidism factor if it is there or not. So we have done prolactin and thyroid. FSH again, day 2. Infertility workup, usual infertility workup in the form of tubal patency, the husband's analysis, yes, for checking the ovulation. All these things, yes, definitely done. And because pathophysiology of the PCOS, apart from this, is associated with insulin resistance also. So some test related with insulin resistance, checking whether it is there or not. In this particular case, we have to do those tests also. So I will like to go for the next question with Dr. Vani, that what are the other measures or markers of insulin resistance. So suppose we have found out that she is a case of PCOS, 22-year-old with oligomenorrhea, amenorrhea, and polycystic ovaries on ultrasound. She wants to conceive, but we want to know whether the insulin resistance is there or not, because it will help us in knowing in further managing that particular case. So let's check. Please let us know what are the different markers for the insulin resistance. Dr. Vani?
Is she there? I have not seen her.
So anyone else can consider this question. What are the various measures by which we can identify the insulin resistance in any diagnosed case of PCOS?
Good evening,
Ji.
Professor.
Ji, sir.
Yeah. So, yes, ma'am. So, with the markers, other marker for the insulin resistance, like when we're dealing, so in that case, we can look for the overall BMI, waist circumferences, and again the waist hip ratio. Along with this, we can say that the patient having the feature of the insulin resistance, like a double chin or having the acanthosis nigricans, and also sometimes skin tags are all there or not. So these all factors may the marker for the insulin resistance. So this is the clinically. Otherwise, history is also very much important in such of the patient.
Ji, thank you, Doctor. Yes, you are absolutely right. We have clinical markers, which are basically the surrogate markers, as you have told, BMI, presence of acanthosis nigricans or skin tags, central obesity, which we identify with the help of waist circumference if it is more than 88 centimeters, or waist hip ratio more than 0.8 in an adult woman. It is suggestive of that there are possibility of insulin resistance, and we can do lab test in the form of either the fasting insulin as well as fasting insulin to glucose ratio. And HOMA-IR, of course, is said to be a preferred one, although it is not very direct evident, but HOMA-IR, which is actually calculated by the formula, that is fasting glucose into fasting insulin divided by a factor of 405. If the value comes out to be more than 2.5, it is considered positive, means the woman is having, or the particular person is having, insulin resistance. So we should go check all these things also in our patients, which help us in identifying whether the patient is insulin resistant or not.
Shikhaji, I would like to add that amongst the surrogate markers that have been mentioned over here, that is the waist circumference and the waist hip ratio.
Yeah.
They are actually more for the fat PCOS.
Yeah.
But now bony anthropometric marker, that is the wrist circumference, has also come up, which is being considered as a good marker for insulin resistance, both for lean as well as obese PCOS. So that can also be considered as one of the markers.
Yes, you are absolutely right. Clinical markers, which all have mentioned here, are basically associated with obese PCOS, and our case actually was a lean PCOS. This patient was having a BMI of just 22, we are discussing today, but currently is a lean PCOS. So of course, we can take the help of this lab test also, and as you said, another is wrist circumference. So just want to enumerate, add on this at this point, that lean and overweight PCOS, they don't have much different presentations. They have almost similar presentations. Clinical signs are same in the form of irregularities of the menses, hirsutism, endometrial hyperplasia, anovulation. Hormonal profiles are also similarly affected in both the cases, like both have hyperandrogenism, altered LH-FSH ratio, altered less of progesterone, more of testosterone, means the estrogen progesterone ratio is also altered. Insulin resistance is almost there in. The thing which is different between obese PCOS and lean PCOS is the severity. The derangement severity is much more in obese PCOS, and these severities, when they remain for a longer period of time, they ultimately lands up in chronic problems in the form of type 2 diabetes, endometrial hyperplasia, more frequently and at an early age in the obese PCOS. So this was just a basic differentiation. Rest of the things like insulin resistance and other metabolic abnormalities in the form of dyslipidemia, this is there in both the types, lean as well as obese PCOS. And another thing which has recently been identified on research is why the lean patient is having all these complications, the metabolic problems, as well as the hormonal problems. This is suggested that it is the chronic low grade inflammation which is developing and happening in the fat cells. So obese patients have more fat cells, they have more chronic inflammation. So the symptoms are more severe, presentations are more severe. While the lean PCOS, they have a lesser of that thing, but it is the basic key factor is suggested to be a chronic low grade inflammation, which is brought by cytokines like TNF alpha. And these things, they cause the inflammatory load, and this inflammatory load is responsible for all systemic and metabolic disorders, which includes excessive leptin, reduction in the adiponectin levels, and of course the changes in the insulin ratio. So we have done all those tests which Dr. Meenal has said. In our patient, most of the tests are within normal limits. USG, yes, definitely a polycystic ovaries have been found. Husband semen analysis are normal. EB, proliferative endometrium, AMH has come to be 9 nanograms per ml, and she was found to be insulin resistant because HOMA IR was 4 point something. So the next question is, now how will we manage this case, this lean PCOS with positive insulin resistance, which this is what we have come up till now. So the question goes to Dr. Aruna. So let us know, how will you manage her?
Okay, thank you, Dr. Shikha, just making the part of this panel. As we already told that lean PCOS and obese PCOS, both of them are having the same metabolic problem, but the difference is only obesity. Okay, so here also the first and foremost part of management is lifestyle modification. Here, the weight loss is not necessary, but here the weight maintenance is important by just doing the moderate intensity exercise like walking, yoga, strength training, etc., which helps to improve insulin sensitivity as well as cause the ovulatory dysfunction normality. As well as dietary change is concerned, they should more focus on the low glycemic index foods and balanced meals. And the processed food, sugar, and refined carbohydrates should be avoided. Stress again aggravates the hormone imbalance, so it should be curtailed by doing meditation and mindfulness. Okay, as well as the medical management concern, here the need of ovulation induction. So here the ovulation induction is done mainly by the letrozole in the doses of 2.5 for 5 days, and further follicular monitoring followed by the things which should be done. And if they are not responding to letrozole, clomiphene can be, but letrozole the first line. Clomiphene can be added and HMG can be used, as well as metformin, which is a insulin sensitizer, should be added, as well as in the patient, like in obese patient, we give it in lean patient, so as to relieve the insulin resistance. And if the
Yeah.
Can I interrupt?
Ji ma'am, sure.
I just want to say that in this particular case, as AMH was quite high, and HOMA-IR was also raised, so in this case, I think that we should do OGTT also, and then proceed, because we can consider her as a case of preconception care type, and OGTT also, and then we should give metformin for 2-3 months and then do ovulation induction rather than doing it coexist.
Thank you, ma'am. आपने मेरी सारी लाइनें ले ली. That was the thing which we wanted to say. Yes, the lifestyle modifications, diet and exercise scheduling is very much important in these thin PCOS cases also. And because she is already, we have tested for fasting glucose and insulin, and she is found to be insulin resistant. Yes, of course, we can go for OGTT also, because she is found to be insulin resistant. So yes, of course, it is always better that we should start insulin sensitizers early with the diagnosis itself, along with the ovulation induction. So first thing is to manage the if it is a glucose intolerance, also manage the insulin resistance part also. Then only the ovary will be able to ovulate well, and the ovas produce, the oocytes will be of much better quality. And the induction effect of letrozole or clomiphene, whatever we are using as a first line, of course, letrozole is much more safer, less chances of OHSs is there. And PCOS patients, they often land up into either they don't ovulate or sometimes they hyperovulate also. So that's why all these three things, and weight control, this thing is very much important. Rest, this figure says that whatever is the presenting symptoms, we have to treat accordingly. In this case, she was 4-year married life, and she was eager to conceive, so that's why we were focusing on the part of ovulation induction. Otherwise, if there is hirsutism, acne, or different menstrual abnormality, whatever is the presenting sign, if she don't want to conceive at particular time, depending on what are the presentation, we have to manage her accordingly. For menstrual irregularity, she can be given OCPs if she doesn't want to conceive. But here our patient is like she wants to conceive, so we are focusing on ovulation induction once the things has been checked and pathophysiology has been managed. Thank you, ma'am. The next scenario is another young girl, that is 14-year-old, 1 year past her menarche. She is presented with amenorrhea of 2 months. She has a past history over 1 year that she has been having oligomenoric cycles, that is 60 to 70 days period. She's having hirsutism also with the FG score of 10. BMI is 28 kilograms per meter square, a bit high. And because parents got कि उनको थोड़ी घबराहट होती है, and then they got an pelvic ultrasound also done, which showed multiple follicles per ovary of 4 to 7 mm size. Her breast and axillary hair development is normal as per her age. So with this thing, the question goes to Dr. Kanhaiya Agrawal. What is the diagnosis of this case, and how we will approach in this particular case of young adolescent 14-year-old? Dr.
Thank you,
Kanhaiya.
ma'am.
Ji.
Yeah, thank you, ma'am, for the question. This is actually the commonly seen presentation in the OPD. So many adolescents come to us also in OPD with such symptoms. So first of all, as we have discussed earlier also, that diagnosis in the adolescent is quite tricky. It is very challenging. We do not follow the common dictum as per the adult PCOS guideline. But the thing is here that the 1 year post-menopause, post-menarche, the up to 6 cycle in of the menstruation cycle in a year is normal in such group of the patients. And also we say that up to 60 days of the this one of the menstrual cycle delay is also quite common. However, the USG finding is not be taken into consideration in terms for the adolescent PCOD. Few things I will just want to add, like whenever the ovary volume is going beyond 13 ml, we can say that this is just a marker, a surrogate marker to have the PCOD. However, the family history of diabetes, family history of obesity in the mother or family history of diabetes in that the patient might be having possibility of the PCOD. We should also look for the other features of the insulin resistance as we have discussed. To others hormonal parameters we can also go in that cases. So I will say that this might be just a normal obesity or metabolic derangement of this group
Hello, आवाज आ रही?
patients. So I will just say that Yeah, I'm audible. Yeah, lot of the
जी
patient
जी
are
जी
taking,
सर.
yeah, lot of the patient are taking lots of the junk food. So lifestyle changes is very much important. Physical activity recommend that every day 30 minutes walk is important. So after the lifestyle, if the patient is not able to lose the weight, we can look for the other possibilities for the diagnosis of such group of the patient. Sometimes the Cushing disease is also very much common in such group of the patient, young Cushing disease. Also, we can go for the hyperprolactinemia, or the patients having, if the feature having the feature of the hyperhirsutism or hyperandrogenism, we can also look for the other possibility like adrenal tumor also. So for this lady, this girl, I will not say that that is the PCOS case. So I will just deal as a whole, and I will try to rule out the other causes, not making diagnosis, but ruling out the other causes of the possible causes.
Thank you very much, Doctor. You have clarified the thing that yes, because she belongs to an adolescent age group, our Rotterdam's criteria does not fit on her. Adolescent is the area where the pivotal changes are already going on, taking place. Oligomenorrhea, amenorrhea is a common feature there. Some acne and hirsutism part is also quite common in this age group. So we don't believe on just the acne and hirsutism for the diagnosis. We just don't believe on a 2 months amenorrhea. And of course, the pelvic ultrasound is complete no at this age point of time. We don't need to go for AMH testing at this age of time. So this is what for the hyperandrogenic identification. If we feel that excessive hairs are there, or if the acne is excessive, or some other different pattern of hair distribution is there, it is always better to check for the biochemical evidence for confirmation whether it is an ovarian or an adrenal levels if excessive hair growth is there. So whatever is the presenting symptom, depending on that, we should go for some of the tests. So sometimes we nowadays come across, and the laboratories are also come up with advertising with PCOS profile, and they present to our doctors that this is the PCOS profile and we should go for this profile in all the patients who has been diagnosed or suspected to have PCOS. So what do you have to say on this profile testing kind of a thing, which includes a good number of battery of tests like DHEA, DHEAS, 17-hydroxyprogesterone, LH, FSH, and many more. Dr. Kanaya. Hello.
I think his internet is not.
Yes, ma'am. Thank you, ma'am.
Dr. Kanaya,
So
are you
like
able to listen me?
the patient
Please be a bit loud.
definitely they are very much
I think some internet connection problem.
Shikha ma'am, can we ask the
we can go
experts
for
to
the LHFSH.
जी
Hello.
जी सर
Yes,
आवाज
sir.
थोड़ी
सुन रहे हैं, हाँ.
Yes, now we can hear you.
Hello.
आप
Yeah. Yes,
हाँ
ma'am.
जी
Yes, ma'am. Yeah. So in that case, definitely we can go for the higher. In that case, the case of hirsutism. So doing the testosterone, DHEAS is also the found to be helpful. But whenever the value of DHEAS is found to be 2 times upper limit of the normal, definitely we have to go for the other testing like 17-hydroxyprogesterone, stimulated level of the 17-hydroxyprogesterone. We can go for the dexamethasone androgen suppression test to rule out the androgenic causes for the this hirsutism. So, so in normal range or slightly above, we can just
Excuse me, Shikha ma'am.
I think
Just to sum up, can we ask one of our experts to conclude this question?
yes.
That would be better.
Reena ma'am.
Unmute
Hello.
करिए.
Hello. I will request any of the expert to please give.
Reena ma'am is speaking, but she is not
Acha.
unmuted. Yes.
I would request Dr. Seema. She is also there. Please call her.
Seema ma'am.
Yes, Shikha, what is the question actually? What part do you want to ask me?
मैम हमारा क्वेश्चन है कि आजकल सब लैबोरेटरीज एडवर्टाइज करते हैं पीसीओएस प्रोफाइल उनके पास उपलब्ध
नहीं, ऐसा नहीं करना है।
पीसीओएस प्रोफाइल
ना ना
with a good number of
PCOS is
criteria of test.
yeah. PCOS is mostly clinical diagnosis and a diagnosis of exclusion that we should know. Unless we are very sure that there are other disorder, endocrine disorder that we should focus on or address on, we should not be wasting time in putting so many investigation and wasting patients' money. And for adolescent age group, actually they don't need much investigation, and all that they need is I use the term catch them young. If somebody is, you see the feature that they might develop PCOS in future, catch them at a very early stage and go for lifestyle modification. If you check their age at a young age, it is very easy to control. Otherwise, what we are witnessing these days, that the patients are coming with more than 100 kg of weight, and they are asking for weight reduction where you can really do little, especially those who have infertility also. So we are getting many cases who are so obese and they want the treatment for obesity, and some have no time also, like they are approaching almost 35 years of age. So for adolescent, my message is not to do too many investigation, rather give too many advices so that they don't put on lot of weight.
Thank you, ma'am.
Totally agree with Dr. Seema, because so all those investigations which they give in PCOS profile, because they give PHES, 17 alpha, all that is not routinely required. Simple total testosterone is enough. Even if we want to calculate free testosterone, that also we can calculate by that free androgen index. So because free testosterone is quite costly, total is comparatively less. So that may be good enough in routine cases. If levels are very high, then of course we can go for the other tests like DHES, etc. If levels are more than 155, then.
Yeah, Dr. Saroj, very high level will go with the clinical picture also. Like then it will not be limited to just hirsutism. There will be and like clitoromegaly and other things will be there, and of course those are the cases who need lot of investigation to reach to a diagnosis and to give them appropriate management. Most of them are PCOS.
We should give more stress on diagnosing their hyperinsulinemia, rather than only going towards that side.
That's what I've said, that they should caught at a young age, and they should, that advisors should start at that stage of when they have not really put on so much of weight. And it is very easy to check in adolescent their weight, because they can do a lot of exercise, jumping, everything, aerobics they can do. At a later age, things becomes really difficult.
Ji, ma'am.
Basically, at this stage, the case you are discussing is a borderline case, and we need not go for so many investigations. Clinical scenario will suggest you which investigation to go for. इसमें ऐसा कुछ नहीं करना है. The 23 guidelines, you take it, and definitely it is not clear cut. Shikha?
Hello, Reena ma'am.
Ji, ma'am. Ji, ma'am. So, as such, everyone has discussed 2023 international evidence-based guidelines on adolescent PCOS says that we should not go for Rotterdam's criteria. For hyperandrogenism, if the features are there, then we have to be it should be proven biochemically by the test, as the testosterone is the test best for the ovarian origin of androgens. But if the excessive hairs are there, maybe clitoromegaly is there, hoarseness or voice may be there, these abnormal features are there, then we can go for other specialized tests depending upon the presenting features. Pelvic ultrasound should not be used for the diagnosis of PCOS with the gynecological age of less than 8 years post menarche. So up till 8 years of post menarche, for diagnosis of PCOS, the ultrasound doesn't have any role. This is the very important thing, and we should not go for this. There are something called as PCOS mimickers. So what are these PCOS mimickers? Dr. Garima, hello, Dr. Garima? Hello?
I think she's not there.
So anyone else? Dr.
Dr. Shikha Sachan.
Yeah, Shikha can answer it. What are the PCOS mimickers?
Anything which actually may cause hyperandrogenism picture, ma'am, like non-classical CAH or Cushing syndrome as such, or as such other endocrinological disorders like hypothyroidism or isolated premature adrenarche. These are the known PCOS mimickers because they lead to a picture of hyperandrogenism, which we know is a very basic thing for the pathophysiology of polycystic ovarian syndrome. So
Yes,
even
right.
obesity is one of the PCOS mimickers which may lead to that.
Very rightly said that we have basic 2-3 presentation in the case of PCOS. One is the menstrual irregularities and anovulation, which ultimately lends to infertility, and the another one is the hyperandrogenic features and obesity in the PCOS case. So anything which presents in that form can mimic a PCOS phenomena. In adolescents, we all often get confused because they are at the verge of pubertal changes. So these are the all PCOS mimickers, and sometimes the patient doesn't fit into any of these, and when it doesn't fit in any of this, we call it as at risk PCOS. So this 14-year-old girl of ours fits into a case which we call as PCOS mimickers, and as all our experts have also discussed, the test should be advised just based on what are the presenting features. So if we get excessive hirsutism, the testosterone levels are very high, the hirsutism grade score is Ferriman-Galloway score is very high, then only we should go for other tests, like maybe the adrenal androgenal problems can be there. There may be signs of virilization, clitoromegaly, excessive growth spurt, then we should go for 17-hydroxyprogesterone, thinking it's a case of non-classic form of congenital adrenal hyperplasia. So basically, obesity, Cushing syndrome, adrenal hyperplasia, these are a bit more intriguous type of mimickers. But yes, if we take a history and we do a proper examination, we can come across some of the findings of any of the different presentation of these phenomena, and then we can easily go through a selective group of tests which can help us in diagnosing if these rare disorders can come across. Thank Next, this patient now has been identified as an at-risk PCOS. We cannot label her as PCOS because she's just 14 years and having oligomenoric cycles, but she is a bit obese because her BMI is 28. So the next question goes to Dr. Amita Tripathi. How will you manage her? How will we manage her this case?
Thank you, Dr. Shikha, for giving me this question. I think my question has been answered by so many of us before. The first and foremost thing for this young girl, she's a teen girl, only 1 year into menarche, is lifestyle and behavioral modification. And we all have discussed, we have to, the teen girls, especially, she's very young, we have to see what diet she is taking. But these girls are very fond of taking processed food, high sugar intake food. So we can take help of nutritionists also and see what food she's taking. She can keep a food diary. और उसके बाद we can tell her that she should take food which is a balanced diet, that is carbohydrate, complex carbohydrate with low glycemic index foods like complex carbohydrates, complex cereals, fruits, vegetables, the fat that is a good quality fat, and the protein, the lean protein coming from the plant origin. And we must see what is the portion of our diet. And then again, the diet along with proper exercises. The habit forming starts from this age only. So if we can see what is her routine, 14 साल की लड़की है, class 8th या 9th में होगी, she's going to school. So उसको exercise में what is her preference for the exercise? School में कितनी देर PT classes चल रही है? What can she calculate? So at least 30 minutes of exercise 5 days a week, Yeah, 60 minutes of exercise she can do twice in a week, and then strength training is also very important. So if she can inculcate these things, this will benefit her. And we must tell her that these small changes, if she can lose weight for 3 to 4 kg, or we can say 4 to 5 or 5 to 6% of weight, we can tell her she will get benefited for the menstrual problem also, and some amount of hirsutism also, and of course she will help. This is helping obesity, and it will go in the long way. And for hirsutism, it is, I don't think we have much to do for at 14 years of age. It's a mild hirsutism with this scale only 10, but we can, if it is in patient important hirsutism, we can tell her she can go for the cosmetic measures, nothing, but not much is needed. Only after this, if she's not getting relief, we can think, but not at 14 years age. We can give OCPs for a smaller period for 7 days or for the withdrawal only.
So thank you, Dr. Amita. I think because diet and exercise is absolutely very well explained. This is very much important, which we focus on, and we should give a 2-3 minutes time to explain the girl itself and well as her mother, so that she follows her and she ensures that she is following those things, because that's the age, as Dr. Seema madam has also said, that that's the age. If we find out and if we can manage well. And if we will manage this at this particular time, we can delay the problems, we can delay the complications, because it's not only the hormone, it is also this lifestyle which adds up very much synergistically and complicates the life of a woman in a case of PCOS. Secondly, because she is amenorrheic, she is having periods at 2 to 3 months interval. So what is important to say, if she is bleeding at 2 to 3 months interval, it is good enough, because 4 to 5 cycles in a year is good enough at this age group. We should not be very much worried, and this should also be explained to the parents, because they usually gets worried that the girl is not having a period at monthly regular intervals. So if she is spontaneously having periods at 2.5 or even 3 months interval, that is good enough, should be counseled like that. And if it is more than that, yes, of course, we can give progesterone withdrawal to have at least 4 to 5 cycles in an year. That is good enough. Cosmetics, if it is, yes, of course, some facial thing which is worrisome, we can go for some of the local treatments, palliations. If BMI is very high, as it has been seen, we should also go for again testing for glucose intolerance as well as insulin resistance, and based on that we can start. If it is there, insulin resistance is there, we can add on insulin sensitizers at this age group. This is the thing which I want to emphasize, that at this 14 years of age, if the findings are there, if the clinical signs are there, and it has been proven by the lab test also, so we can add insulin sensitizers at this age group also. But yes, OCP should not be started at this age group of 14. It should be started after the at least 16 years of age, when most of the epiphyseal closures are there, to maintain the menstrual cyclicity. So this was all about this particular young age group. So now the next thing comes up when we think about or say about OC pills or the progesterone. Which progesterone or which OCP has to be given for these adolescents, or 16, once she reaches to 16, 17 years, or if she is coming at that particular time, which progesterone, which kind of a OCP should be prescribed? Dr. Priyanka.
Yes, sir. Good evening, everyone. For this child who is now crossed around 16 years of age, I would like to give her hydroxyprogesterone straight for the withdrawal. And if she continues that my cycles are not regular and I want to have the regular cycles, and we have to start the OCPs, and because androgens levels are right now increasing, so we can put her on low dose oral contraceptive pills with the anti-androgenic progestins, with the combination of ethinyl estradiol along with the drosperinone or with cyproterone acetate or desogestrel. And if we have to see now after 3 to 6 months, what is the response with the OCPs, along with the dietary modification and lifestyle modification with the menstrual cycle. So we have to check it
Thank
like
you.
that.
Absolutely right. Once we are She's coming to at the age of around 14 years and she's presenting with amenorrhea. We need just to have give some medication, that is progesterone, to make her menstruate at least at 3 to 4 months interval. So medroxyprogesterone is yes, of course, the first line treatment for that withdrawal kind of a bleeding. After 16 years of age, we can switch on or regular low dose or very low dose oral contraceptive pills. When we plan for shifting her for the oral contraceptive pills, again, they have two basic things to see. If hyperandrogenism is the primary affected thing in the patient, then we should choose oral contraceptive pills which have cyproterone as a component because it has a high anti-androgenic effect, while those which have a menstrual irregularity as a primary affected factor, then the OCPs with drospirenone or desogestrel are the better options. We should give this treatment for 5 to 6 months and then stop this thing and check whether the things has come up to normal on its own, because she has been also been kept on weight reduction, diet, and all those things. So if she is maintaining all those things, she may attain a regular menstrual cycles. If she is able to control the weight of at least 5 to 10% reduction, she may come up with the regular menstrual cycles also. So while giving an cyproterone acetate, this one thing is to be very well checked, that this is the drug which is on research found to be associated with increased risk of venous thromboembolism. So whenever you prescribe, we should check at least the thrombotic risk of that particular patient. So actually we are dealing presently with the young patients, very young, so they are not much at that risk. But yes, of course, we should think over and just have few questions to assess the VT risk before prescribing cyproterone acetate. So the next scenario, this same girl has now got married. She has turned 22 years. BMI is still 28. FGS score is 8. She has still mild hirsutism. She is continuing with her diet and exercise pattern, taking low dose oral contraceptives to maintain her menstrual cyclicity. And now she wants to conceive and she has come to us for the preconceptional counseling. We got her tested with some of the tests and we found that her oral glucose tolerance test report 2 hours were 180 milligram percent, HbA1c was 6.2, and lipid profile was also mildly deranged with slightly raised LDL. So this was the scenario which has come up. So what should be the plan for this particular case? Dr. Shikha, to please answer.
Yes, ma'am. Now she has turned 22 and she has come for preconceptional care. And as we can see that she's having glucose intolerance and her 2 hours 75 gram OGTT is also 180 and HbA1c is also 6.2. So along with lifestyle changes and dietary habit changes, which we have talked a lot till now in panel, we now need to add an insulin sensitizer to her treatment plan. I think metformin should be added to actually bring down that hyperandrogenic environment which she's having, because she's still showing some signs of hirsutism and everything. So I won't go into detail about lifestyle modification and dietary habits, which we have already discussed in panel. But we need to work also the infertility workup if she is coming here and she has come for infertility, ma'am, or just for preconception care? Just for preconception.
She wants to conceive, so she wants to take preconceptional counseling. She has come for
So
actually
along with
preconceptional counseling.
along with that, we'll go on with all the infertility workup, which was very nicely discussed in the first case by you and Dr. Aruna. We'll do all those infertility, that is HSG, semen analysis, and other factors and hormonal profile also. After adding insulin sensitizer, we'll go for ovulation induction. And as very rightly told by you, there are two drugs with the letrozole and clomiphene, but the drug of choice remains letrozole. And then we can give progesterone support in the luteal phase on induction cycles to this patient.
So yes, thank you. Almost things are similar as we discussed in the lean PCOS case, who also wanted to conceive. So this is again, she was till date she was on OCP. So we will stop her OCPs. We will inform her the basic regular continuation of her exercise and diet plan. straightforward, there is no need to go for the complete workup, but yes, we can start working on, because she's now planning, so she can wait for some of the time if she's menstruating regularly, and then we can go for the other test. uh, Metformin, yes, of course, is an important thing, because to start at this stage, because she has got insulin resistance also, and she has got an oral glucose tolerance test which is abnormal. Ovulation induction testing, and whenever we do an ovulation induction in this group of patients, this should actually be started after the weight reduction. If she is an obese category, as such as this is our case, where her weight is excessive, BMI is 28, we should wait till she lose at least 5% of her initial weight, and then only start giving an ovulation induction. And once we start an ovulation induction, those cycles, luteal phase support is very much important. So this is the here again I want to emphasize, although it has been discussed, because once we control the obesity, we reduce the weight, it reduces the insulin resistance, it induces the menstrual regularity, it induces the ovulation, it induces the more chances of pregnancy and a better pregnancy outcome. So this is what, by just controlling the obesity and the reduction of weight, can do lot of things. And of course, the psychological support, the stress reduction, these two things we often forget, but we should counsel the family members on that aspect also, so that a holistic treatment is required for such cases, because we know that these patients will take time to get pregnant, they may take time. Again, after this thing, the next step, if nothing happens and she is very obese, then the last option comes up is the bariatric surgery. Whenever the BMI is above 40, we should go for this kind of a thing. If there are comorbidities, even at BMI of 35, we can plan for bariatric surgery. But this surgery has its own complications. And whenever someone goes for bariatric surgery like Roux-en-Y or sleeve gastrectomy, at least 1.5 to 2 years time is to be given before she plans her next pregnancy. So this is not that simple, and should be taken care only on those very high risk patients. Now, this same patient, as Dr. Shikha said, we have given the ovulation induction with letrozole. She was continuing with her diet as well exercise plan, but and also the metformin as she suggested, but still after 3 cycles of letrozole, she was not able to get the pregnancy. Ovulation induction failed. What should be our next step, Dr. Meenal?
Shikhaji, I would like to add something over here. That we have talked about the bariatric surgery and all, and I would like to, since we are having the specialist with us, what is the take on these weight loss agents, the oral weight loss agents that are available over the counter and available nowadays? Before going for bariatric surgery, what is the take on the use of these agents?
They should be subjected to pharmacotherapy, and if they don't respond to it, only then they go for bariatric. I think Dr. Kanaya is there to enlighten us. पहले तो फार्माकोथेरेपी देंगे ना, उसके बाद जाएंगे.
हाँ नहीं मैम, फार्माकोथेरेपी तो दे ही रहे हैं, लेकिन जो वेट लॉस के लिए जो स्पेसिफिक एजेंट्स हैं, जो अर्ली स्टार्ट वगैरह है, हमारे पास एब्यूटेरामीन है, ये सब हमें यूज करना चाहिए कि नहीं करना चाहिए?
हाँ, they are to be given. दिया ही जा रहा है.
Ma'am, GLP-1 drugs have come up in a huge way, also in PCOS women, and now there's the talk of Ozempic babies. That is the obese women who started Ozempic, conceived naturally when they were failing all sorts of fertility treatments. So definitely, in today's scenario, that is a treatment option that needs to be offered.
So coming to the question that I have been asked, that this lady has not been able to conceive, that there is ovulation failure with the drugs, letrozole along with metformin. So for me, I would like to take up this patient for as a case for IVF, and I would not like to take up for any other option, but straight on go with IVF, since letrozole has she has not ovulated with letrozole, and letrozole is the first choice drug according to the recent guidelines, and an IVF protocol with GnRH antagonist specifically, not using any gonadotropin protocol that can lead to OHSS in such patients, and better is to take her up for IVF directly. We can also use second line agents of gonadotropin therapy, and laparoscopic ovarian drilling is there. But my choice would be better to take her up for IVF and not waste time with gonadotropins, because with whenever we are giving IVF, we are again using the controlled ovarian stimulation with gonadotropins. So, and if we are using gonadotropins alone, there are more chances of multiple pregnancy, less successful birth rate, and IVF offers us the chance of the opportunity of single embryo transfer, and a better quality transfer and high oocyte yield is there with IVF. So my take will be IVF.
So thank you, Dr. Meenal. I think here can be a two different group of people on this particular take, because she is just 22-year-old at present. She's not 35 or 38 going towards the. So I think there is no harm in waiting for some more time, giving more emphasis on reducing some more further weight, bringing the BMI to as normal as possible, adding insulin sensitizers like inositol along with metformin, replanning some ovulation induction, as you have also told, that we can increase the dose of letrozole, we can go up to 7.5 also. We can add on with gonadotropins, that is FSH or HMG, depending upon what kind of the condition is she's having. And yes, of course, a laparoscopic ovarian drilling is a good option in such a case. We can give a try for this particular thing also. If it doesn't work, yes, of course, the last resort we can go to IVF also. But of course, if this patient has been of 35 years age group, yes, I would also have suggested more in favor of IVF. So this is my perspective. I think experts can give their opinion also on this.
I agree with Shikha 100%. We should wait a little, give more insulin sensitizers and gonadotropins. With low dose step up gonadotropins, we can go, and FSH alone I will prefer in this case, not HMG.
Yeah.
And then I think we should wait a little. LOD we can do, but with gonadotropins alone, with minoxidil and that, we can wait for some time, and then
it has been suggested that inositols also added along with metformin, they gives a synergistic effect. So sometimes if we have kept just on metformin, we can add further with myoinositol or decaro-inositol combination. This reduces the overall metformin dose also, increases the tolerability, and the ovulation rate as well as the oocyte quality is also said to be bit improved with this combination. So we have good number of insulin sensitizers. Metformin and inositols are the most common ones, and which can both be used simultaneously or added on in the same particular woman, which helps us in getting the pregnancy.
Can I say something?
Dr.
Dr. Shikha,
Yes.
at 22, she got married. Since when is she trying pregnancy is important? Because 22 is just a tender age these days for getting married and trying a pregnancy. If she has not tried for 1 year, just in 1 year time, she can lose weight and can add on to metformin and allow her wife to give letrozole at a early stage. By the time they come to us, they have already received 6-7 courses of ovulation induction, and then we are not left with any other choice, as Meenal said. But why to start ovulation induction so early? In a very young patient, I think we should advise them to go for weight loss. है ना? इतना जल्दी क्या है कि जल्दी जल्दी लेट्रोजोल दे दो, आराम
एक्चुअली जब
से
14
उसको
साल में
समझाओ,
जब 14 साल में डिटेक्ट किया ना मैम, तो वो इतना घबरा गए कि अब टाइमली शादी हो गई,
but
टाइमली
still
मैं
she has
प्रेगनेंसी
a
कर
hope, na? With weight loss and all, she has a hope. If she doesn't conceive, then Give her
Yes.
some time and then tell her to bring down the BMI to at least 25 from 28. That
Ji.
will be a very motivating factor for her to lose weight, because anyway, even if we go for IVF and all, with so much of weight, everything becomes difficult. With less weight, we will be more successful in trying ovulation
Give her,
induction or in
yes,
trying IVF.
give her at least 6 to 8 months
Ji.
for her to come back to the normal BMI.
जी
और
जी
give her a task, है ना, एक टाइम फ्रेम में टास्क दे देने से they do it and they do conceive.
जी
I think it becomes really very simple that if you write target weight on their prescription, ये तुम्हारा ideal weight है, height in centimeter -100, ये ideal है, थोड़ा कम करो, 78 से 68 तक लाओ, 65 तक लाओ, तो target weight के बाद they start working something.
जी जी. So now I will hand over the panel to Dr. Amrita to please make it
Okay,
forward.
ma'am. Since we are running short of time, you continue with the presentation. I'll just speak. You continue sharing the slides. So we won't waste time in changing the slides. So, ma'am, we were discussing about the girl. She was 22. We gave her enough time. Although we did, we gave letrozole, etc. But her IVF was done later. And now she conceived at the age of 34 years. And the second IVF cycle with metformin, diet and lifestyle measures running. Her HCG test is now positive. So what should be the management plan for her pregnancy? Since Dr. Vani is not here, I would like to put up this question to Dr. Priyanka Shishodia, if she is there. Dr. Priyanka, are you there?
Yeah, good evening, ma'am.
Yes, she's
Ma'am,
there.
right now she is 34 years and conceived with IVF second cycle with metformin and diet and lifestyle measures. I would like to do start her up on low dose aspirin along with the folic acid, and would like to do the HbA1c levels and see what was the diabetic control over the last 3 months. And again, we can also see what is the associated risks, such as hypertension is quite common in 34 years of age along with the diabetes patients, and counseling and progesterone support for the early pregnancy can be given, and along with the level 1 ultrasound or dating ultrasound to be done, and to look for the fetal viability, and dietary modification we can do it for her.
Okay. So coming to the this case, we would definitely add low dose aspirin for her, folic acid supplementation for her, and we would suggest that if she's a smoker or if she takes alcohol, she should stop that. And metformin may be continued in her early pregnancy. And as you rightly said regarding the HbA1c assessment, we would like to put up a question to the experts whether we should do a glucose challenge test for this patient or not. This question is to the experts.
Sorry?
The glucose challenge test we usually do for all the patients. And for this PCOS patient who is obese and everything is there, and she is already an IGT patient, are we supposed to do a glucose challenge test for her or not?
Definitely, we'll do
Yes.
glucose challenge test in this case also, and at that too at the first time, because although she was already getting metformin, but even then we'll do glucose challenge test also. And in this case, I will definitely like to continue metformin at least for 12 weeks, because
Yes.
otherwise the chances of miscarriage in first trimester are to a great extent. So continue with that, and of course, as routinely we are doing glucose challenge test thrice in pregnancy. In this case also it has to be done, and if in doubt we can even repeat it earlier also.
And ma'am, what is your take on the low molecular weight heparin use in such patients?
At least I will not give it in this case, because I will not give. This much is good enough, because this is her first pregnancy.
Yes,
Yeah, enoxaparin
So
would
molecular
have been given to her if she had repeated implantation failure. But this, she conceived with the second IVF cycle. So there, and if other parameters are okay, there is no need. But if she had repeated implantation failure, then in that condition we can give enoxaparin.
And also, one important thing is that she has conceived after IVF, and there's always a risk of ovarian hyperstimulation syndrome. So we should keep a close follow-up up to the 8 weeks of pregnancy. And rest, the antenatal care has to be as the high-risk pregnancy follow-up, and we will take good care of her. So there's a question to Dr. Kanaya Agarwal that what is the role of metformin in PCOS pregnancy and how long it should be given? She's already a
not
case.
there.
Ma'am,
I
can you
don't find him on the board.
Okay.
कोई भी
So,
डॉक्टर
ma'am, please change the slide. Then. So, metformin is a category B drug and it's safe in pregnancy. It crosses the placenta, but no major malformations have been noted till date. And if pregnancy is achieved with metformin alone, it should be continued in early pregnancy, as Dr. Saroj Madam rightly said. And it can be continued throughout the pregnancy up to 36 weeks if she is obese and her BMI is more than 30. Although we have been told repeatedly that metformin should be discontinued in the third trimester. So I would again like experts to intervene in this and please guide us regarding this.
क्या बोल रहे हैं?
मैम मेटफॉर्मिन कहते हैं कि
why to discontinue in third trimester? It has to be continued, otherwise the blood sugar level will rise. Rather in third trimester,
it is not that now.
Many times you have to
You can
increase the
continue
dose.
in third trimester.
To be GTN.
So if
Okay.
there is impaired glucose tolerance or BMI is raised, we should continue it.
Up to 36 weeks. So RCOG and Endocrine Society, they recommend the continuation of metformin. Next slide, please. So here is another question to Dr. Aruna Verma, that what are the comorbidities and complications with PCOS pregnancies? Dr.
Yes,
Aruna Verma, ma'am?
Yes, Hanji. PCOS, it is seen that it increases the risk of adverse fetal maternal outcome, and it is primarily because of hormonal imbalance and insulin resistance, as well as chronic inflammation, which was told by Dr. Shikha. So, they are causing problems with the fetus as well as with the mother. In the early pregnancy, the chances of miscarriage, the abortions are increased, and these are almost 3 times higher than the normal pregnancies. And it is mainly because of poor oocyte quality, insulin resistance, and luteal phase defect. And it is seen that there is increased risk of ectopic pregnancy, and it may be because of chronic inflammatory process. And the later part of pregnancy, there is a high risk of gestational diabetes mellitus, hypertensive disorder in pregnancy, preterm and placental insufficiency, and abruption. Again, these are because of endothelial dysfunction, metabolic syndrome, and again chronic inflammation. And because of gestational diabetes mellitus, the risk associated with GTM like macrosomia, shoulder dystocia, and neonatal hypoglycemia are there. In the fetus, there are high chances of macrosomia, neonatal hypoglycemia, as well as NICU admissions and parental morbidity. In the interpartum, it is seen higher chances of cesarean rates are there, and it is again because of macrosomia, fetal distress, and failure of progression of labor, and high chances of labor induction. In the postpartum period, there are high chances of postpartum depression due to hormonal imbalance as well as associated psychological stress. And delayed lactation is again there, which is again related with hormonal imbalance, and persistent metabolic syndrome in type 2 diabetes mellitus is increased. So, in the partum period, the patient should be followed for metabolic problem as well as for the diabetes mellitus.
So
This is all
very
for the
well.
comorbidities and complication associated with this problem.
Thank you, ma'am. Very well answered the question. So there is a series of problems which occurs right from the first trimester till the postpartum period, including the perinatal death of the baby. Preterm delivery is very common because of the hyperandrogenemia. Next slide, ma'am. So the role of BMI and hyperandrogenism. High BMI and insulin resistance are associated with an increased risk of spontaneous abortion in PCOS. And PCOS. Okay, next, you can change, ma'am. Yeah. So we all know that fetal developmental programming is there, and there are many epigenetic factors. In the prenatal period, there are endocrine disruptors, and in the postnatal, obesity, etc. The genetic predisposition is always there. So maternal PCOS and fetal genetic predisposition can lead to prenatal excess androgen, and the fetal reproductive system is also affected. And fetal metabolism is also affected. There is increased insulin secretion and increased visceral adiposity. Still, the baby can suffer from IUGR and impaired nutritional milieu. So all this can lead to, if the female fetus is there, then she can be prone to PCOS. And if the male fetus is there, he can suffer from the metabolic syndrome. Next slide, please. So this leads to a scenario. Same Miss B is now 40, para 1 and 1 living child conceived with IVF, we all know. She now presents with her 8-year-old daughter stating that she has pubic and axillary hairs since past 4 months and sudden progressive weight gain over 1 year and no much height changes. So how she should be worked up and investigated? Dr. Garima is not there, so any of the panelists can take up this question.
Ma'am, I think she's 8 years old. She's showing pubic and axillary hairs. That means adrenarche has already occurred,
Yes.
and there is also weight gain. So, and also this is a daughter of a chronic PCOS patient.
Yes, ma'am.
So just now, as you told, there are two theories. In case of if there are certain epigenetic changes which are brought about in fetus. In case of persistent hyperandrogenism in utero, these epigenetic changes might have made this young girl a little more predisposed towards the early onset PCOS. And the second thing, that, like you told, even if she is an IUGR, and we call about Baker's hypothesis, that she's again has a high risk in that case for this. And so we need to now, like Seema ma'am said, catch them young. So this is the case which is showing other things, and we should carefully monitor us and have a detailed history with if she's taking anything else apart from genetic factors which might be causing these type of symptoms. So family history is already there, and her personal history and drug history has to be taken. And then we have to obviously examine her and investigate her for possible signs of hyperandrogenism and other insulin resistance.
So, so what is the diagnosis of this patient? And discuss the management plan. The same girl, 8 years, stating that she has appearance of pubic and axillary hair past 4 months and sudden progressive weight gain over a year. So, Dr. Amita Tripathi, the question is to you.
This young child is having, we have to examine this patient, see what is about her thilarchy, and we have to see the growth of clitoris. And in examination, we have to ask about what hormones, if her mother has taken some hormones in her life. And we all know that her mother has suffered from PCOS all her life. Then we have to test her by LH and FSH testing, and we can test for other things to rule out we have to rule out central precocious puberty and peripheral precocious puberty. So to rule out the peripheral precocious puberty, we have to go for testosterone testing, dihydroepiandrosterone testing, 17-hydroxyprogesterone testing, and rule out non-classical adrenal hyperplasia and other things. If the androgens are very high, we have to rule out other things. So this girl is, I think, is having LH level as LH level. So I think this patient is suffering from precocious puberty that is of central origin, that is gonadotropin dependent precocious puberty. So discuss the management plan. The goal of management plan should be, the thing that happens with these girls, they attain, they have sometimes short stature because of fusion of the epiphysis early. So the goal of management is to give her a plan so that her bone age should be maintained, and we can halt the progress of puberty and to allay the psychological anxiety, because this young child is the daughter of the woman who has suffered from PCOS and its aftermath her whole life. So here I would like to take consultation with our pediatric endocrinologist. Apart from lifestyle modification as the first line therapy, we can give her insulin sensitizer or metformin after testing, insulin resistance testing. And with the help of pediatric endocrinologists, sometimes one can give GnRH analogs which can decrease the gonadotropin, and they can be given at leuproid acetate long-acting gonadotropins monthly in the dose of 100 microgram per kg per body weight, and they should be given for up till when the bone maturation has been maintained and she has achieved the whole weight. And usually this is given up to 11 years of age. And in between, we have to monitor her with the hormone testing, that leuprolide, estrogen, and uh, these things.
Okay. So we should not forget that the premature adrenarche patient are at risk PCOS, and lifestyle modification is a must for such patients in this era of mobile and screen time which the children are using. So they need to limit their screen time also. They need to have good sleep also, diet and counseling and exercise they have discussed much. And metformin can be initiated for this girl of 8 years, and it should be maintained throughout the puberty for another 4 to 5 years. Rest we can take care of with the leuprolide, which Dr. Amita has said, but we will not take the decision very quickly about giving her gonadotropins. And I would like suggestions from the experts regarding the use of leuprolide for such girls, for this girl.
Sarojini, why leuprolide? She does not show other testing which are suggestive of precocious puberty. I think her lifestyle modification, weight reduction will help her at this point of time. I don't think she needs leuprolide.
Yes, ma'am. This I wanted to bring up.
Treatment what Amita has narrated is mainly for precocious
puberty. Yes, ma'am. Because she is not having breast at this time. There is no menarche. So we do not need to give her leuprolide to this patient.
Yes. Only metformin, only insulin sensitizer.
Sensitizers are to be given. Yes, ma'am. So there is a phenomena which is two-hit hypothesis. That is, insults during the prenatal life constitute the first hit. Endocrine and metabolic imbalances occurring later in life may act as second hit, which through activational effects unmask or amplify the modifications programmed prenatally, culminating in the development of adult disease. So we need to catch them not only young, we need to catch them in the prenatal life itself if we want to protect them from being PCOS patients in future. Next slide, ma'am. So now this Madam B is 47 and she's satisfied with her one child only, but she is now presenting with irregular menses and mood changes. Her BMI has increased too much. She is 32 kg per meter square. So how will you manage this patient? And what are the investigations and screenings which are required at this age? Dr. Shikha Sachan, please.
Yes, ma'am. Ma'am, she's now 47 years old, but her BMI has also increased to 32. So the first change she has to do is obviously to reduce her weight by doing lifestyle changes and changing in her dietary habits. Now she is having irregular menses and mood changes. Irregular menses, we all know that with PCOS, we need to do endometrial screening also in this patient. And we need to assess if she's having other signs of hyperestrogenism, as she has been exposed lifelong to hyperestrogenism. So we need to assess the endometrial thickness, and if we need to do anything about that, if it is more than 7 mm, we need to further follow her for that. Obviously, this is the time at this point where all the chronic complication of PCOS could be assessed in one thing. So like she was already showing insulin resistance, we can screen her for her in diabetic potential. And obviously, this is the stage where we can get a lefty done for metabolic syndrome associated metabolic syndrome associated hepatosis or liver changes. Lipid profile
Non-alcoholic
should also,
fatty liver disease.
it has been
Non-alcoholic.
changed, so I was learning that. पहले NASH था,
Okay.
अब शायद उसकी terminology change होगी. It is metabolic syndrome associated liver dysfunction now. I
Okay.
also read this yesterday ना, इसलिए I was trying to use that. We are more convenient with NASH, तो हम वही बोलते हैं, but it has changed. And this is the time where we can assess her bone health also, and breast and mammography or sonography can also be done.
We need to check for endometrial hyperplasia because such patients are prone to endometrial cancers also in future. So transvaginal sonography and assessment of endometrial thickness and a PAP or endometrial biopsy if needed.
Yes,
Next slide, please. So management is again the dietary approach to stop hypertension and low carbohydrate balanced diet, exercise, and we need to manage diabetes, dyslipidemia, and the non-alcoholic fatty liver disease appropriately with the physician. Next slide, please. Of course, the psychotherapy is very, very important at this stage. And she is into menopause transition. So hormonal changes are very, very important, and androgen levels remain high as women enter menopause, while estrogen levels are declining. And the metabolic changes, there is long-lasting hyperandrogenism. This may magnify unfavorable hormonal and metabolic changes related to menopause and increase the health risk. And the persistent health risk is of impaired glucose metabolism, enhanced ovarian androgen secretion, and chronic inflammation observed in premenopausal women with PCOS. This persists after menopause, the inflammation in the fat tissue. And she is already 32 BMI. So this is a busy looking slide, and what happens, what are the long-term consequences, PCOS and menopause, the visceral adiposity, the insulin resistance, the increased endothelin, increased angiotensin, decreased NO secretion, all this leading to oxidative stress and hypertension, the chronic inflammation, altered adipokine secretion, pro-inflammatory cytokine secretion, the upper airway collapsibility, especially in obese patient. Now she is prone to the sleep apnea, and also there is a chance of hypertension, type 2 diabetes, dyslipidemia, metabolic syndrome, atherosclerosis, endometrial cancer, obstructive sleep apnea, and mood disorders. So these are the long-term complications in the PCOS patient: the obesity, glucose intolerance, hypertension, and dyslipidemia. There are various studies which suggest that all these patients can suffer from the problem. Due to the paucity of time, I'm not reading the slides. Let's go to the next slide. The mood disorders increase, and the potential cause, of course, obesity is one cause of depression, infertility, another cause of depression, hyperandrogenism, and insulin resistance. They are proposed to play a role. Proposed interaction between PCOS and obstructive sleep apnea is there. PCOS, because of the obesity, can cause OSA, and menopause itself can lead to obstructive sleep apnea. So there is marked increase in prevalence of OSA during menopausal transition in general population.
Sorry.
Okay, so let's go to the final slide. Mrs. Brown, she's now 51. 15 months past her first final menstrual period. Her BMI is 32. taking antihypertensives for 5 years, anti-diabetic medication for 1 year, experiencing severe vasomotor symptoms and genitourinary syndrome of menopause. So what is her diagnosis and how are you going to manage her? Dr. Priyanka Shishodia. Dr. Priyanka, are you there? So, Dr. Meenal, you can take up this question.
Priyanka is there.
Okay,
Yes.
Priyanka.
Ma'am, she is on antihypertensive for last 5 years and anti-diabetic medication with the BMI 32. She is most likely to be at risk of endometrial hyperplasia and endometrial carcinoma. And she is also developing the vasomotor symptoms. So, along with the lifestyle modification in the management, we would like to do some routine tests for her also, like TVS to see the endometrial thickness, to rule out endometrial hyperplasia, because she is at very high risk of developing the endometrial hyperplasia and further can be at risk of developing the endometrial carcinoma. And according to the endometrial thickness, we can proceed with the endometrial aspiration biopsy. And she has developed vasomotor symptoms along with the GSM. So we have to manage her with the lifestyle modification, weight reduction, and dietary modifications. Along with the, if the vasomotor symptoms are very severe, we can put her up on SSRI or SNRI for short duration, and gabapentin and clonidine patch can also be given for her.
Okay. So if there is any contraindication to MHT, then only we can switch to the SSRIs or selective noradrenaline reuptake inhibitors like paroxetine or venlafaxine. Because now the MHT or the hormone replacement therapy is the preferred treatment for the symptoms of the menopause, especially if the patient is suffering from GSM. We can give transdermal estrogen patches, 25 to 50 microgram per day, weekly per day, and estradiol gel 0.5 to 1.5 milligram per day, given once a day. So in case if there is contraindication, then we can switch over to other drugs. And yes, please.
Just for the genitourinary symptoms, we can use the
Yes.
vaginal route as well.
Yes, ma'am.
Yes, the moisturizer.
You have to use local
Vaginal.
estrogens for GSM. And regarding vasomotor symptoms, this patient is having hypertension, diabetes, no problem. But then she can go for this transdermal route. But then you have to give progesterone also, maybe progesterone IUCD for her, because she's always at risk for hyperplasia also.
Okay. And one thing I would like to add, that she's already on an anti-hypertensive. So we can review that whatever anti-hypertensive medication she's taking, and we can select the beta blockers for her that would help in these vasomotor symptoms as well, apart from controlling the blood pressure. So we can also review on
Blockers
that.
are not much effective for vasomotor symptoms, what I feel.
Yes.
Beta blockers are not preferred.
Blockers are not much effective for vasomotor symptoms.
No, ma'am. They will be acting as just an additional boost. It will help in the control of the blood pressure also, and anxiety and palpitations would be suppressed by that.
Okay. So emollients and lubricants for the symptoms of GSM are still the first line drugs, but local vaginal estrogen can be given to the patients. Estriol cream 0.5 milligram daily for 2 to 3 weeks. Estradiol or estrone creams in the by the name of Primarin can also be given. There are estradiol vaginal tablets. It can be given, and there are certain vaginal drinks which can be taken by the patient, and patient can easily remove them and reinsert the vaginal rings which they are in the form they are available. And a word about ospemifene. It has to be given 60 milligram per day. It is a selective estrogen receptor modulator and has a selective role for the vaginal tissue. It has an estrogen-like effect on the vaginal tissue and an anti-estrogen effect on the breast and the endometrial tissue. So this is a very good drug, but not available in our country. It is available on Amazon, etc., but it's not available in our country for the medications.
We are also having this combination available with by the name of Duavi, the conjugated equine estrogens along with bezidoxifene. That has been approved.
Bezidoxifene is there. Yes,
Yeah,
ma'am.
that has been approved for the treatment of vasomotor symptoms, and that will help in will act as an antagonist on the uterus.
The drugs
And-
have to be FDA approved. The drug controller of India has to approve these drugs, and they have not approved it yet, and so it is not available in the general market also. Till then, we have to withhold. We can't use it. Maybe it is available on Amazon.
No, but
Can I
spironolactone
say
many
something,
times we need to add, because sometimes hirsutism is very severe. You need to add spironolactone.
Can
But
I
the
say
thing is,
something?
Yes, ma'am.
For
Dr. Seema.
vasomotor symptom, first we try non-pharmacological treatment like lifestyle modification, and she should stay in a cool environment. Her room temperature should be more like on the lower side so that she doesn't feel hot. Most of the cases, we can help them out by giving them simple advice. And if they are not responding and they have really severe symptoms, then only we should try local estrogen that can be tried for 1 to 2 months. That will not do any harm even in hypertension and diabetes. But first, of course, non-pharmacological treatment has to be tried.
Yes.
Yes, ma'am, very rightly said. We should ask her to reduce her caffeine intake. If she's an alcoholic, she should stop taking alcohol and she should not smoke. That is also very, very important, especially in the modern scenario, which we are seeing in the society. So there are other treatment plans also. If she is having hirsutism or acne, then spironolactone is the drug. It blocks the androgen receptors. Flutamide is an anti-androgen drug. It's also androgen receptor blocker. Finasteride is 5-alpha reductase inhibitor, which stops the conversion of testosterone into dihydrotestosterone. Lipid-lowering agents are a must in metabolic syndrome. And as we were talking about the anti-obesity drug, that was Orlistat, we can give to the patients for the reduction in weight. And atorvastatin can be given in cases of statins can be given, simvastatin or atorvastatin in cases of dyslipidemia. There are certain cosmetic agents also. Eflornithine cream for the facial hair growth. It's not a hair remover. It slows down the hair growth. And topical retinoids for the acne or topical benzoyl peroxide for acne. There are certain newer agents, GLP-1, that is glucagon-like protein 1 analogs like liraglutide. And this helps in reducing the obesity and the insulin resistance also. Vitamin D has a very good role. It has come up as a hormone now, not really a vitamin only. And omega-3 fatty acids should be added in the prescription. Next slide, please. So this is another slide showing the management at various age groups, 25 to 30, 30 to 35, more than 35 and above. So we can take up the best is always there. The first line is always there, the lifestyle modification and dietary restriction if they want to conceive letrozole and CC. And in 30 to 35 years, again, the same. And insulin levels should be assessed and insulin sensitizers are to be given along with myoinositol and dichloroinositol. So we have a doubt and we place this question to the experts whether metformin alone works well for any age group of patients or we should add myoinositol, chiroinositol with metformin for the management of the patients. Any age group.
I think metformin itself is a very good insulin sensitizer, and independently it works very, very well. But then, if it is not working, the response is not that very good. Yes, of course, the others can be added. What I feel.
Many times metformin causes a lot of GI problems in some of the patients. Then of
Yes.
course it becomes easier that to add myonistal and then give it to them. Otherwise, metformin alone is good enough in majority of cases, as Dr. Rina said.
Yes, ma'am.
Dr. Anuradha wants to say something. Dr. Anuradha, you please have your comments.
Dr. Kanaya.
No, Dr. Anuradha is there. She wants to say something. We can't hear you, Dr. Anuradha.
Ma'am must have joined with delegates link से तो नहीं join किया है.
Ma'am, what I wanted to say was that the dose, it was regarding the dose of metformin only, that we can give it from 500 milligram to 2000 milligram of dose. But at times, 2000 milligram dose is not very well tolerated, as Madam Saroj rightly said.
Yes.
Then
Very,
in
very
those
right.
cases, we should definitely add myoinositol and dicarbonate along with the this metformin. So,
नमस्कार अनुराधा जी.
नमस्कार सरोज जी. बहुत अच्छा
नमस्ते
discussion चल
आपकी
रहा है.
एक्सपर्ट ओपिनियन.
मैंने थोड़ा सा इनपुट ऐड करना चाहा जो अभी डाइट में चल रहा था, कि जब शुरू से ही हम डिस्कस करते हैं पेशेंट को कि वेट लॉस करना है, तो ये आपका विटामिन डी, ओमेगा 3 एंड gut biome is still not discussed.
Microbiota.
Yes, ma'am.
gut biome अगर ठीक होता है तो हमको सच पूछिए तो माइस्टॉल देना ही नहीं पड़ता है, because of that deficiency of gut biome, ये हमारा नेचुरल बी कॉम्प्लेक्स है जो माइस्टॉल हमारी बॉडी में पैदा होता है, वो पैदा ही नहीं हो पाता है बिकॉज ऑफ द डिस्टर्ब गट बायोम. एंड काउंसलिंग का बहुत बड़ा रोल है, वेट का. और अगर हम बैठते हैं पेशेंट से काउंसिल होने, तो इनसाइड इज अ कॉज इज द डिप्रेशन, कॉर्टिसोल. उसका कॉर्टिसोल इतना हाई होता है, उसका पीयर ग्रुप उसका मजाक उड़ा रहा होता है एडोलेसेंट ग्रुप में. नॉट ओनली पीयर ग्रुप, एडोलेसेंट मैरिड लाइफ में उनकी जो होती हैं जेठानी, देवरानी, सास, उनका भी स्ट्रेस इतना ज्यादा होता है. जब उसको आप जब तक एलिवेट नहीं करेंगे ना, तो खाली मेटफॉर्मिन या खाली ये दवाइयां काम नहीं करती हैं. बिकॉज दिस इज माय पर्सनल, we all are facing the same thing. So this is very important. And adipokinin जो हमारा पीसीओ का होता है, जैसा हम लोग अभी तक डिस्कस किए, फीटल ओरिजिन ऑफ डिजीज, तो ये एडिपोकाइनिन की मेटाबॉलिज्म ही शुरू से ही गड़बड़ होती है. वो एडिपोकाइनिन हमारा ट्रेंड हो गया है कम खाने में जिंदा रहने का, तो जब ज्यादा खाना मिलता है तो वो फिर काम ठीक से नहीं करता है, और वो फिर फैट सेल्स हमारे हाइपरट्रॉफी हो जाते हैं. तो बहुत अच्छा डिस्कशन चल रहा है इन्फ्लेमेशन पे. सो मैं बहुत ज्यादा फेवर में नहीं हूँ कि एडोलेसेंट एज ग्रुप में या अर्ली टीनेज में उसको हम लोग 20s तक में भी बहुत ज्यादा ओसीपी दें, क्योंकि ओसीपी जो होता है वो खुद में इन्फ्लेमेटरी. तो जहाँ पे हमारा ज्यादा हर्सिटिज्म है, तो 6 साइकिल्स डायनाप्रोस्टोन दे देने से कोई दिक्कत नहीं है, दे सकते हैं. बट कॉन्सिक्वेंटली जो मेरी प्रैक्टिस है, मैं उसमें एवरी 14 डेज से एवरी 10 मिलीग्राम बीडी फॉर 12 to 14 डेज देती हूँ. विड्रॉल ब्रीडिंग अलॉन्ग विद ऑल दिस लाइफस्टाइल मैनेजमेंट. और काउंसलिंग तो हर बार ही करनी पड़ती है कि तुम जैसी हो बहुत सुंदर हो, और गोरा रंग नहीं चाहिए, हर्स्यूट है वो धीरे, जैसा मेंशन किया हम लोगों ने, एफ्लोरेथिन लगा सकते हैं, रेटिनॉइड लगा सकते हैं, लेकिन तुरंत तो वो जाता नहीं है ना. तो उसका फिर कॉस्मेटिक है. आजकल कॉस्मेटिक में ये अल्ट्रासाउंड या लेजर से हेयर सेबुलेशन हो जाता है, बिकॉज ये लुक बहुत मायने रखता है आजकल. पहले नहीं रखता था, पहले पीयर ग्रुप टीज नहीं करता था. अब हमारा पीयर ग्रुप एडोलेसेंट का हो, चाहे यंग वुमन हो, चाहे वो घर की एनवायरनमेंट हो, वो इतना ज्यादा टीज करता है कि हम कहते रह जाते हैं ना तो लेट्रोजॉल काम करेगा, ना तो एचएमजी काम करेगा, कुछ नहीं काम करेगा. तो उसको हमें काउंसलिंग से ही ठीक करना है. उसको एक अच्छा मेंटल बैकअप चाहिए. तो सच पूछिए तो न्यूट्रिशनिस्ट भी चाहिए साथ में,
और एक साइकोलॉजिस्ट भी चाहिए, क्योंकि हम लोग अपनी बिजी ओपीडी में इतना समय नहीं दे पाते। तो मेरी अपनी ये प्रैक्टिस है कि हर मतलब न्यूट्रिशन पे दे दीजिए उसको। और आजकल तो लड़कियां पढ़ी लिखी हैं, सबको यूट्यूब आता है। तो मैं कहती हूँ लाइफ स्टाइल मैनेजमेंट तुम पीसीओ में देखो और क्या क्या डाइट लेनी है, बिकॉज माइक्रो न्यूट्रिएंट्स भी अभी तक डिस्कस नहीं हुए। इसलिए मैंने थोड़ा सा कहा मैं अपना इनपुट देना चाहती हूँ। बिसाइड दिस ओमेगा टी देयर आर मेनी मोर माइक्रो न्यूट्रिएंट्स। तो वो किस डाइट से क्या क्या हमको मिलने चाहिए, हम क्या क्या एड ऑन सप्लीमेंट्स कर सकते हैं इन फॉर्म ऑफ कैप्सूल्स और टैबलेट। बिकॉज ये पूरी जो मेटाबॉलिज्म है यही गड़बड़ हो गया फीटल ओरिजिन में। फिर हमारा जब वो इन यूट्रो थी, फिर उसके बाद जब वो पीयर ग्रुप में गई, फिर वो जो एनवायरमेंट में गई। और आजकल खाने में तो हम सभी देख रहे हैं कि धनिया में महक नहीं है, गोभी में स्वाद नहीं है, कहीं कुछ है ही नहीं। ऑक्सीटोसिन सप्लीमेंट्स, डीएनबी सप्लीमेंट्स एंड डाइऑक्सिन सप्लीमेंट्स, यही सब तो भरा पड़ा है। तो रियली वी आर हैविंग अ वेरी मच डिफिकल्ट लाइफ। और ऑफ कोर्स पेरीमेनोपॉज, मेनोपॉज जैसा आप लोग डिस्कस कर रहे हैं, बहुत अच्छा डिस्कस कर रहे हैं। सो दीज वर माय फ्यू इम्पोर्टेंट टिप्स व्हिच आई थिंक कि मुझे कह देना चाहिए। हर गट बायोम के लिए मैं खास तौर से एम्फेसाइज करूंगी, मैं कभी प्रोबायोटिक नहीं खिलाती हूँ किसी भी पेशेंट को। हर एक को कहती हूँ तुम गन्ने का या सिरके का, गन्ने का या जामुन का सिरका लिया करो, 1-2 चम्मच जरूर। तो 3 महीने में मैंने देखा है गट बायोम बहुत अच्छा हो जाता है। और गट बायोम अच्छा हुआ तो ये इन्फ्लेमेशन भी चला जाता है और हमारे सारे नेचुरल विटामिन काम करने लगते हैं। और फ्रूट डाइट, वेजिटेबल डाइट रखो और मिल्क प्रोडक्ट्स को अवॉइड करो। सो आई थिंक डाइट काउंसलिंग एक अलग से होनी चाहिए हर पेशेंट की।
Yes,
हम लोग उसको
that
बता
is
सकते
a big chapter. Yes.
हैं। या बिग
Yes.
चैप्टर या थैंक यू सो मच।
Thank you for your inputs. And there's one more question from us. That is that cyproterone acetate is given left and right to the patient for hirsutism, especially by the dermatologist. So when we know that it has a lot of side effects of VTE, etc. So should we prefer drosperinone or cyproterone acetate in such patients?
Cyproterone acetate is more effective
Cyproterone
than
for
drosperinone. For
hirsutism
androgen,
cases,
for
है ना?
hirsutism
But
is
then
more
it should not be continued for more than 6
yeah,
months. उसके
that's
बाद
what
then
I
give
said.
a pause.
नहीं, फिर आप उसको ना एक एंडोक्रिनोलॉजिस्ट से कंसल्ट करके इंस्टेड ऑफ गिविंग एंटी एंड्रोजन लाइक ड्रोस्पेरिनोन और साइप्रोटेनोन एसिटेट स्पाइरोलेक्टोन पे दे सकते हैं।
Yes, ma'am.
स्पाइरोलेक्टोन के
Now,
साइड इफेक्ट
You
अलग
can change it.
हैं। So
Yes.
we should
now
do a
even in
combination treatment.
now even in ASHRAE's guideline, the drosperinone is first choice and then second the cyproterone.
Yes, ma'am.
Yeah.
Second पे आ
Yes,
गया।
ma'am.
पहले तो cyproterone ही first था उनमें।
नहीं, ज्यादा हिर्सुटिज्म हो मैडम तो ड्रोस्पेरिनोन उतना काम नहीं करता है। गाइडलाइन जो भी लिखो, इतने 40 साल का
Yes.
मेरा एक्सपीरियंस
अगर
खुद में ही
obviously
काम
hirsutism दिख रहा है तो for 6 months we
हाँ
can
तो
very
yes,
easily give,
yes,
उसके बाद stop कर दो, क्या
हाँ,
करना है?
हाँ, ठीक है, बिल्कुल बढ़िया।
ठीक
और
है।
जैसे मैडम ने कहा कि काउंसलिंग 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 सबसे ज्यादा इम्पोर्टेंट आई थिंक
हर बार
में
हर
काउंसलिंग
बार
ही है, चाहे वो वेट रिडक्शन के लिए हो, चाहे वो डाइट के लिए हो, बट काउंसलिंग एंड लॉन्ग ट्रीटमेंट विच दे हैव टू टेक। सो
वो पूरा इतना बढ़िया डिस्कस किया आप लोगों ने कि इन यूट्रो से लेके
a
एडोलेसेंट
big round of applause for Dr. Reena and her team.
हाँ,
Yes,
थैंक यू।
very nice. It was very well
Dr.
covered.
Shikha and Dr. Amrita has worked so hard to bring it out.
Dr. Shikha,
My
Amrita,
thank you to
and
both
all
of
the
them.
panelists,
So,
all
ma'am,
the panelists who have done it very nicely, because it has covered all the parts, right from 8 years to 51 years तक सब कुछ cover किया है. It was really very nice.
मैडम
thank you, ma'am.
51 तक नहीं, टिल शी इज अलाइव,
जी
Yes, ma'am.
टिल
Till
शी
she
इज
is alive.
अलाइव। ये जो डिस्लिपिडीमिया है ना, ये भी इन्हीं बच्चियों को होता है। बाद में चल करके ओबेसिटी डिस्लिपिडीमिया का भी 5 पीसीओ है, हार्ट अटैक्स, व्हाट नॉट, मैलिग्नेंसी, एवरीथिंग। तो अच्छा है कि जब अब हमारी डॉटर्स हमारे साथ हैं तो हम उनका ध्यान रखें कि
जी
वो फीटल ओरिजिन ऑफ डिजीज ना पैदा करें।
जी
वो
और
ठीक है।
जी
जी
मैडम, इससे पहले
So
कि हमारा ये वो खत्म हो, हम डॉक्टर भारती जो हमारी डायनेमिक सेक्रेटरी हैं और जो कि वाइस प्रेसिडेंट के लिए खड़ी हो रही हैं इलेक्शन के लिए, हम सभी की ड्यूटी बनती है कि हम सब उसको होल हार्टेडली सपोर्ट करें। भारती बहुत बहुत सारी बेस्ट विशेस। भारती हो अभी? भारती,
भारती है नहीं।
आर यू हियर?
No, she's not there.
बहुत सारी best wishes and we all are.
We are with you.
हाँ, हम सब लोग भारती को सपोर्ट कर रहे हैं. मैंने भारती को बताया
Yes.
और भारती बनारस आ भी रही है. We all are supporting.
So now we can conclude the session, Dr. Priyadarshini.
Ji, ma'am. So, thank you all panelists for this excellent discussion. Thank you all seniors for your excellent contributions and inputs. And as we come to the end of this wonderful session, I would like to thank all our esteemed experts and moderators for the time and their valuable inputs, all dignitaries for their encouragement and presence, our technical team and organizers from UPCOG as well as the Endocrine Committee UPCOG, and last but not the least, our enthusiastic audience for staying with us throughout the session. So all I say is let us continue to learn, share, and grow together as a community. Thank you, everybody. Have a wonderful evening. Thank you.
Thank you, Shield, also. Thank you for
Yes,
giving
thank
us
you.
the
Thank you,
IT
Shield.
platform.
For
Yes.
providing the platform, the
Sahiti
IT
and Shield
support.
team.
Site.
So thank you all of you for being here for a session which was very much in my mind to present in front of you in all, like from 8 years to 51 years you have just described, because PCOS, every time there is a case and people, there are so many valid prescriptions coming for it, which is not valid also. So that has to be taken care of, and that's why this panel was planned. So thank you so much, all of you.
Thank you.